give everyone a minute or two to get in, and then we'll get started. Looks like a good show. Um, I think it's 11:02, so we'll start. Welcome everyone. I'm going to quickly turn it over to Guy and welcome to the May Primary Care Program Advisory Council meeting. And should have this streaming live on YouTube. Apologies for last time we had an issue with the live stream. We were able to get it online afterwards, but I know folks who are looking to join were not able to immediately. So our apologies for that. It should be corrected this time. Guy, let me pass it over to you for welcome and remarks.
Great, thanks, Brad. Thank you so much for joining. I'm excited about today's meeting. I think this is a really important one. So our last meeting, we walked through a straw proposal. We got a lot of helpful and frank feedback from you all, which I think was very useful. We've taken a lot of that feedback. I'm not going to say we've accepted all of it, but we've really listened and taken a lot of it. I think our primary goals of this meeting are to play back what we heard from you, show you what we've incorporated, have a discussion about that, and then talk about next steps. So I think it's going to be I hope it's going to be a productive meeting. I want to encourage people to continue, which I'm sure you will, to be frank and vocal and have a robust discussion, which is always helpful. And then just on a quick personal note, I think many of you know, at some point in the next handful of weeks, I am going to be stepping down as Medicaid director. My extremely talented and qualified successor, Bill Halsey, whom many of you know, is on today. I want to say I have 100% confidence in Bill. Many of you have worked with Bill for a very long time and know him to be a leader of integrity and intelligence. And Bill, I don't know if you want to, I know you aren't able to stay for the whole time today, but I don't know if there's anything you want to say right off the top for the period of time that you are able to join us today.
Yeah, thank you, Guy. I just want to say thank you for those kind words. So I have been following this project from afar. I know that it is a key and high priority project for the department, and I just want to say I look forward to working with you on this project. I will be working and connecting with the DSS team to make sure I'm fully up to speed exactly on where the committee is on this, and then I look forward to working with you in the very near future. And I'm sorry I can't stay longer today, but again, I look forward to working with everyone. Thank you, Guy.
Great. Thanks, Bill, and thanks, Guy. And just to say, I've had the pleasure working with both of them, and Bill as previously when he was in the role of Medicaid director. So I'm very, very confident and know his abilities well from reporting to him for quite some time as well. So that definitely sad to see Guy leaving, but no, we're in very capable hands. So thanks for allowing for that at the top. And I think we can jump into our agenda for the day and we'll set up our goals. So next slide. Great. So this is just our design goals. You've seen these many times. Just a reminder that really you're trying to improve the biopsychosocial health and well-being of Husky members, especially for those most historically disadvantaged, in a way that reduces inequities and racial disparities. And then we can go to the next slide. And as a reminder, we phased this work, our primary care program design process. We are ending phase 2. This is a somewhat almost separate extra meeting to make sure we wrap that up. We wrap this process up well and effectively, and make sure we're make sure we're taking in the feedback responding, and we're planning on ending phase 2 and moving into phase 3 after we conclude the meeting today. So I think we'll go to our PCMH Plus update. I know this has been an outstanding question. After just some ongoing internal discussion, we are planning on extending PCMH Plus for calendar year 25, while the program design work for new primary care programs are underway. And we will anticipate, updating the timing of what's going to happen with PCMH Plus as we have further timelines and dates for launch of a new program. So that'll be part of phase 3 discussions, just making sure everyone's aware. We'll be sending a more formal notification in the coming weeks, which participating entities can hear more about. Joe, I see your hand up on this. Go for
it. Is the position going to be to continue to close the program to new entries for another year?
As of now, yes, that won't change. As you may, Josie, probably are well aware, it's been a RFP based program, so that was how it was set up from the beginning. So it was closed, and to open it back up and to do another RFP would be a fairly significant lift as of now. So as of this moment, there's no plan on doing that for this next calendar year. But understand the question, and I just want to acknowledge we've heard that there is interest from other groups and to consider joining PCMH Plus. And I will also note it is not our DSS's stance to plan on doing another RFP-based program moving forward as of now. So just want to make.
I just think, Brett, I have to say for the record, this has been going on for some time where DSS has had a program that has excluded entry to a large number of provider groups in the state. And I think at the beginning of this process, it was at least my thought that we've been moving along to doing something for 2025. And to hear that we're going to go now it'll be 2 full years before we start this process, before programs have the ability to participate, that doesn't seem fair and balanced in terms of how DSS is dealing with other provider groups.
Well, just to say, we have our existing PCMH program, our PCMH Plus program. We've done wave 1, wave 2, wave 3. And now we obviously are moving into another year, and it has been several years since that RFP was open, where provider groups could submit applications to participate. So just acknowledging that is something that we are aware of. There's also limited bandwidth to undertake that process, which is not insignificant. It is something I think we will discuss internally, Joe. But I definitely just like we hear the concern. We know we want more participation. I just want to say that. Okay. I think as part of this, we do want that. It's just that how this program, the PCMH Plus program, is structured. There's a lot that goes into doing new waves of it. It's not insignificant work. And Polly saw a question, would not start until calendar year 2026. So, based on our timeline as of now, I don't think it would be very difficult to start something in 2025. And especially for calendar year, we're in May. We have to do technical design. We'd have to do a lot of work to get something launched by, and realistically, as we think about, I think if we go back to the last, maybe the last slide, Olivia, we've kind of said we're starting this in June, but going to December 2024 plus, that's for the design piece. That's implementation will take design and implementation, but implementation will take time. It just does, including getting authority, submitting all the paperwork to get approval for CMS, et cetera. So there's definitely work to be done. It would not be ready for anything would be ready for launch in the beginning of 2025. Mark, I saw your hand up.
Thanks. I'm all right, Brad. I was going to say that it also seems if the governor's announced the intent to implement Medicaid managed care, that would seem to be certainly a factor in terms of how one thinks about primary care reform in that context.
Yeah, maybe I'll take that one. Thanks for the question, Mark. And as many of you know, this will be on the MAPOC. This is on the MAPOC agenda. I'm not sure it's been sent out. It is on the MAPOC agenda for next Friday, so I'm sure we'll have a robust discussion about it then. Just to preview what I know the commissioner is going to say, and Bill and I will also say during that meeting, the governor has given us the direction to explore and to gather data and think about managed care. Definitely the direction is not move the program to managed care, and definitely not the direction move the whole program. So it's a directive to explore and to gather data, not to move. It may eventually turn into a move, but right now it's not. It's certainly not a direction to move. So I just wanted to clarify that. Thanks.
Thank you.
All right, thanks everyone. Appreciate, and I just want to reiterate kind of some of the goals for this work is to create a broad-based program that allows for broad provider participation, and I think we've heard that. We will revisit, I think, the PCMH Plus conversation internally, acknowledging some of the limitations and challenges to having that program be significantly modified at this time. I think we can go to the goals for the day. I think slide 6. So our plan today is to revisit the phase 2 review, cross-cutting equity strategy and DSS supports materials, where there were some comments and we've incorporated some updates. Introduce a refined payment model, again, based on committee feedback, both from this committee as well as from the FQAC subcommittee, and review some of those changes and then discuss next steps on the technical design subcommittee for goals and meeting structure. So I think we can jump right into one. So again, we're going to revisit some of those comments on the cross-cutting equity and DSS support and talk about that feedback and how we've incorporated it. Next slide. The 3 major pieces of feedback here on the left, and then you'll see where what we incorporated into. 1 was the committee recommending DSS pursue Medicaid coverage of health-related social needs services. 2 was the need to educate providers and patients on HRSN initiatives more broadly, in addition to why REL data collection is important. And then a request that DSS work to explore how to streamline access to services within the DSS portfolio. And that one was incorporated into DSS support. So now we'll go to the next slide. And we won't revisit this in detail, but this is where some of the comments came from. Just as a reminder, we reviewed this cross-cutting equity strategy that is in all 3 major domains of care delivery on the left, performance measurement below it, and then payment models. On the next slide, you'll see where we updated the committee feedback. The last 2 bullets, and I'll start with the second one from the bottom, we incorporated in red, so the red's where we've made adjustments. You'll see that we added educating providers and patients on HRSN initiatives. The last bullet is a completely new bullet. I'll just read it out loud. Acknowledging state and federal constraints, members emphasize the importance of supporting community provider capacity and recommended DSS pursue Medicaid coverage of HRSN services in alignment with this work. So again, just what we heard and what we thought we'd be responsive to. This again is the feedback we heard from all of you at the last meeting. On the next slide, we'll add it as well in the DSS supports. So this is the last piece of feedback, the 3rd one. Again, you'll see in red there the new bullet, again, under DSS supports, that opportunities for DSS to help strengthen and support practices in achieving the primary care goals that we've outlined is exploring how to streamline access to services within the DSS portfolio in parallel with this work. So we've incorporated that there. I think, so I'll take a pause and see if there's any comments or questions on this before we move forward. And feel free, if folks want to add later, welcome to come back to it. I think we go to the next slide. So this is part 2. This is on the refined payment model structure. And so here will be, Mark, I see your hand up.
That's a mistake.
Oh, no problem.
I was trying to get rid of the thumbs up on the last set of slides, so I'm embarrassed.
Thank you. Well, that's okay. Happy to take a hand up instead of a thumbs up. We'll dock you 1 point, Mark, for this meeting, but no more than that. So again, the goal is to really introduce a refined payment model structure that based on the feedback we heard from you, will revisit the committee feedback, we'll review the committee feedback. We'll review the refined payment model structure and then collect additional feedback from all of you and see where this lands. So next slide. As a reminder, I'm not going to read through these. These are the design principles that we had laid out in the last meeting to help inform phase 3 based off the conversations that have occurred in this group to date, just as a reminder. Next slide. And then as a reminder, we also outlined state and federal constraints that would be that have to be considered as part of any new programmatic development and implementation, including state budget constraints and federal authority constraints. Next slide. This was what we reviewed last time. So this is the prior original slide from the April 4th meeting. And as you probably recall here on the left, what we had on the top in the blue is the base payment. Underneath that in the table is the incremental payments. And then at the top on the x-axis, you see the small provider and large provider track. And on the base payment, we had brought up the concept of using a primary care hybrid population-based and fee-for-service payment. And we heard feedback on that, and we'll go over that in a minute. And then we did hear feedback about specifically on the tracks, as well as how we laid out the quality performance incremental payments. So just as a reminder, this is what we showed last time. This is what we got feedback on. We can go to the next slide that reviews that feedback that we heard from all of you. So on provider tracks, on one, we heard that there's a recommendation to really think about capability-based tracks instead of size-based tracks, and including a risk-free option. For base payment and flexible funds payment, we heard 3 things on base payment: a preference for maintaining a fee-for-service foundation. On flexible funds, a support for including population-based payments or PMPM payments to really enhance or support care coordination and behavioral health integration. And then also making sure there's an adequate base payment plus an add-on tied to specific expectations and accountability standards. Also heard under performance-based payment, concerns about primary care providers' ability to impact total cost of care. So just acknowledging some of this. On the next slide, there's two other pieces of feedback. So one on the population, so a push for more attention to the dual eligible populations, whether it's within or beyond the scope of this work as well. And then the importance of alignment with other efforts. So one is many of you highlighted the importance of an adequate base rate, or recommended that program design consider potential impact of rate increases over time. So for example, in the context of shared savings benchmark development, when you have a rate adjustment from one year to another. And then also revisit the interest in more comprehensive strategies. So example, regional accountability and or ahead model participation, and highlight the importance of developing the program in alignment with those items. So we're still pending ahead application feedback from CMS. So obviously that it was recommended to be considered as part of this process. The next slide is FQAC subcommittee feedback we wanted to bring to all of you as well. So we present this information first to this overarching committee, and then we have a FQAC subcommittee. On the hybrid fee-for-service PBP-based payment, FQAC representatives expressed interest in a population-based PMPM-based payment, just highlighting that some of the benefits, which I don't need to run through, we've discussed them previously, but they highlighted them for us, so we wanted to call them out. And then on performance-based payment, also expressed some concern about having shared risk begin with the launch of the program, stating it would be more sense for shared risk to be delayed until the program is well understood and established, which we'd heard some of that from this primary group as well over time. On the next slide. So we heard that feedback. And so this is kind of some of the changes we've made, and we'll review a model here. But the 3 major refinements are: one is we did refine the proposal to include capability-based tracks to provide flexibility for providers to select which track, including a risk-free option for all providers, regardless of size. We also wanted to give providers options to transition to a hybrid fee-for-service and population-based payment, while retaining options for a fee-for-service-based payment. And then responded to discussions around further defining the model, and we outlined some key components in more detail for discussion. So I think we can jump to the next slide and dive into this model update. Again, we'll be looking for feedback here. So what you'll see is looks very similar in terms of color coordination. On the left-hand side is the table. At the top are the tracks. So now we're saying track 1, 2, and 3. And we're saying these tracks are capability-based tracks. So all providers could potentially select in. We may have a minimum size. There's some details that would need to be fleshed out here, but really more capability-based. In addition, on the left, on the base payment, you'll now see that track 1 and 2 have a fee-for-service base payment. Track 3 has the primary care hybrid population PM or population-based payment and fee-for-service. And so that is updated. You'll also know under incremental payments that the flexible funds, that the add-on payments are provided upfront for otherwise unfunded activities. And the performance-based payment model, basically is mostly unchanged, but holds providers accountable for quality and for quality of care, and then for shared savings as well as for particular costs that have to be defined. So this was the modifications based on feedback. We'll hear from you in a moment. We're going to dive a little bit more detail on the next slide in terms of program alignment, which I think was asked for. And so in terms of the tracks we just reviewed, so this is based on what you just saw on the last slide, is, we heard the ask to make sure that there is alignment in as much as possible with other models and or continuity. And so what you'll see here in this table is on the left, DSS program alignment, and then Connecticut multi-payer alignment below it. So on the first one under program CTB, DSS program alignment under track 1, the one we just showed where there's a fee-for-service base, it's pretty similar to PCMH, our existing PCMH program, plus flexible funds. Track 2 would be similar to our PCMH plus flexible funds for non-FQHCs. FQHCs currently receive a care coordination PM, plus a phased approach to shared risk. Under track 3, again, somewhat similar to PCMH plus, but it would shift the base payment. There would be additional flexible funds for non-FQHCs, and there would be a phased approach to shared risk. That's kind of the proposal. And then under multi-payer alignment, so again, wanting to align as much as we can, track 1 really is aligned with the state employee health plan, which has flexible funds payment and equality performance P for P component. Track 2 similarly has with the state employee health plan and also Medicare shared savings program aligned. And under track 3, similarly, there's some alignment there with the state employee health plan and MSSP with the addition base payment transformation. That's probably the largest change. And obviously, we're not just talking, this would go beyond this. We would talk more about what exact quality measures we'd be using for alignment purposes, et cetera, but really talking about how existing alignment for moving towards these programs from what we're doing with PCMH plus, as well as alignment between the state employee health plan, primary care program, and MSSP. Polly, I see your hand up.
Thanks, Brad. Just as a point of clarification, I know we had talked about this previously. Is the intent that I'm trying to get my arms around what all this replaces, right? It replaces PCMH plus, any of that attestation process that you might do to get, like, you can also do an attestation to get an increase in your base payment if you take a preponderance of primary care. And then have we, for track 1 in particular, would there be no requirement to be PCMH designated? So from the extent of like removing some of those barriers, maybe in the more advanced tracks, we might keep that, but I just want to also kind of bring that back up as to where that fits into this model. Yeah,
so in terms of the enhanced payment to primary care in general for practitioners, this kind of is beyond that. So it doesn't necessarily remove that. This would be kind of a replacement for our PCMH and PCMH plus programs. It's kind of how this would be focused on. In terms of the question of provider requirements for participation, that would definitely be part of a phase 3 conversation that we'd want to have discussions about and envision that moving forward. We've heard feedback that on some hand that it could maybe really important to continue having some sort of accreditation for accountability purposes. Also acknowledging, on the other hand, there is a cost as well as administrative burden that goes along with doing that. So I think that would be part of a phase 3 discussion, but appreciate the question. And then Ellen, I see your hand up as well.
Yeah, I have concerns. I was very surprised actually to see this plan. It wasn't what I was expecting after the last meeting. I thought we had I just didn't expect to see opportunities for, and it looks like a phased approach in two of the three tracks to move to 100% provider risk, which is concerning. And it feels like it happened after you got input from the FQHCs, which carries its own level of concerns. I guess, and I'm also just reading ahead to the technical committee, the questions that they're going to look at is now just, let's go ahead with this. So this is sort of set, and I wanted to find out if that's true, and then to just ask some questions about whether there are any sort of protections we can put in place to make sure that some of those concerns that I've raised before about primary care capitation don't happen. So maybe a pre-question is this the model now?
I think this is the proposed model to work off of, understanding there would be a lot of work that, as you know, well, and Ellen, I know you know a lot, obviously spent a lot of time in this world. There's a lot in the details. And one question I had, I heard you say 100% provider risk, and I was just wondering, when you say that, do you mean having any sort of shared risk? Is that what you're meaning? Or I just want to make sure I'm understanding what you're saying.
That there would be that there is a potential for providers to be only reimbursed based on a population-based payment and shared savings. There's no fee for service necessarily.
Well, the hybrid one, so the hybrid population-based payment and fee-for-service base, that actually, I think on the next slide, we'll get a little bit into what that definition, where that would need to be defined further, because as and Mark had brought this up, I think last time, there's some definitional need about what goes into a hybrid population-based PMPM fee-for-service space. And the two kind of major options are, worth saying out loud if that's okay, is that option one is where you really have this service array, and basically select services are paid fee-for-service and not included in the PBP or the population-based payment or the PMPM. So, for example, vaccines, maybe those are, as a service category, administration are excluded from the PMPM. Those are paid fee-for-service. Versus option two, where you shift basically percent of that revenue. So part of your history, instead of let's say you get $50 for a flu injection, a provider gets reimbursed 50% of that would be fee for service, 50% of that gets shifted to a PMPM. And so it's basically splitting that. So there's pretty big decisions that still need to be made about how these would be structured in terms of the option. And different programs in other places have done this differently. So option one, where you're really saying kind of everything under the population-based payment falls under this PMPM, and there's no fee-for-service component, that's MCP, or Making Care Primary. Track 3 is doing that, as well as Massachusetts Health ACO program does that, versus option two, where you're taking the same service and you're splitting it up into, you get paid some of it goes into a PMPM, some of it you still need to bill fee for service to generate revenue. That's Making Care Primary Track 2, CPC Plus, which you've discussed, I know, extensively, and then Colorado APM 2 as well does that. So there's still a lot of decisions that would need to go into this in terms of exactly how this would be structured.
Okay, I guess that I feel a little better. But I guess I'll just share when I read this, just my first pass at what kind of protections would need to be in place. And that would I would like to see, this is all just from my head. I have talked to no one about this. So other advocates can pipe up if they disagree. I'm sure others will. That there should be a gate to taking on risk. And I'm concerned about gaming the system, that providers will look at their utilization and their revenues and look at fee for service versus a per month system and decide which one, basically make the decision based on revenue, which is, a business decision, and they should. But I think there's the possibility for the state to pay more for no change in things. I would also think we should think about a quality gate, which you did have in PCMH Plus. And I would argue that it should not be improvement. It should be based on actual performance. Because if you're going to move into a place where we're going to trust you to give you money up front for even some services and just hope for the best, we want to start with the people who are most able to do that right now. I would like a delay. I agree with the community health centers on this, to measure what the impact would have been during a time, to figure out what the financial impact especially would have been if we had done it, just so that, for budgeting purposes. I mean, the state doesn't have a lot of money, and being sure that we're not doing it again, spending money on things that don't add value. I would, again, when you look at net costs, it's really important when you build this time to be sure that you net out costs for ICM, for CHNCT, and other services that, it was acknowledged by Guy's predecessor that we were double paying for some of those services. We were, especially ICM, for instance, PCMH Plus we gave shared savings to entities who had used ICM services. So we paid for those, but the savings or half the savings went to them. It is really critical that patients are fully informed this time, completely, absolutely, no question about it, understand that their provider now is at financial risk, profits by reducing their total cost of care. That has to be really clear to patients, and for them to understand what other options are available to them. And I think, we've never done this, and maybe this opens old wounds, but a discussion of why I don't want to use the word failed, but PCMH Plus has not achieved the goals that we thought about, and I was part of planning it. We had hoped for in the beginning, and we've never really had an honest discussion about why it hasn't, or that it even hasn't. And I think that's, gets tweaked every once in a while in response to concerns, but it hasn't, if you're going to overtip something, I think we should know what we did wrong last time. Those are just my first thoughts. I'm sure I'll have more concerns.
Ellen, just a few thoughts in response, and welcome to others, and obviously happy to open up the conversation here a bit more. But I think one is, I know you raised the concern of gaming, and I think I would just anticipate, there's always going to be, any provider is going to maximize as much as they can revenue when it makes sense. Obviously not necessarily at the risk of patient care, but just, when it makes sense to operate in a way that's going to make sure you're able to pay all your staff and keep the lights on, that makes sense. And you're going to see that in every model we build, whether it's fee for service, et cetera. We just have to acknowledge that that's part of what happens when you build a payment model. And I think Quality Gate, we definitely anticipate having Quality Gate from the get-go. We've built that into our maternity bundle and I know you raised concerns about having an improvement piece of it. I will say, I think we've tried to have both a reward for those who improve, especially substantial improvement. There's different ways of doing this, as well as for those who are performing already at the top. So I think, we're definitely interested in having that and making sure that's a key part. I don't think we would ever consider probably doing a program without a quality gate. And I think we definitely have heard the concern about of risk and how to do that. And I think on the next slide, Olivia, maybe I should just call it out. We know that there's other decisions that have to be made, and really we've said that this is for really illustrative reason, visualizing a discussion only, but we do anticipate taking a phased risk that we plan on it, but there are pending discussions, including with phase 3 and as well as budget discussions for how this would get rolled out. But the anticipated initial approach would be thinking about applying as upside only, and then later you're thinking about a phased approach. And really, that would be using asymmetrical upside and downside risk as part of a kind of stepwise transition and considering different parameters for track 2 and 3 over time. So just say there is a lot that would need to go into that. And I think the only other thing is, I think on PCMH Plus, when we've looked at, Mercer did analysis that included a bunch of costs, there was some savings. We've looked at the quality scores over time. I don't think PCMH Plus is actually not performing. I don't think it's performing poorly or hasn't met any success. I think there's opportunities that we can improve that program with things we've learned about what we need to put into another program to take another step. But I think, Ellen, you were much more involved in creating it and putting it together many years ago with my predecessor and I think his predecessor. But, just looking at it now, I think there's a lot of good things about PCMH Plus. And I will note that, for care coordination, at least with our ICM that CHN runs, is that, it's expected that PCMH Plus practices will do that ICM function at this time. That may have been maybe that was slightly different at the beginning of the program than it is now, but I think those are some, we obviously don't want to double count. And I think we've been very mindful about when we can have community providers do some of that work, we're interested in them doing the care coordination when it makes sense. Guy, did you want anything else?
I thanks for that, Brad. I did want to add a couple more things. And Ellen, there was a lot in what you said, so I'm not going to respond to everything, in part because Brad did, but also I want to be selective and give others the chance to talk. I just want to highlight 2 things. The first thing you said on providers doing the calculation, model A, model B, I very much agree. And as you probably know, there's substantial research that shows that in value-based payment models, there is shopping or gaming or gerrymandering where providers, think about the different options and make the proper business decision for them. So I think that's real. I think, and we've discussed this a lot internally, that exists. There's also the feedback we've gotten throughout this group about the need for flexibility. So I guess what I want to say on that one is I agree. It's a real concern of mine. And I would welcome, not necessarily now, but, thoughts on how to, I don't think we're ever going to eliminate the gaming, but to try to limit it, I think would be really helpful. And I really want to encourage people to give thoughts. That's one comment. Totally agree with Brad on the levels and the changes, right? We don't want to introduce a policy ratchet where we end up inadvertently penalizing our best providers. And I agree broadly on a lot of the budget stuff that you talked through, Ellen, without getting into the specifics on making sure that we're not paying for things twice. More broadly, and neither Brad nor I really knows exactly what the fiscal situation is going to look like. So that's why there are caveats on this slide. But more broadly, we're going to have less money than I think everyone would like for this program. And I think in phase 3, we are going to have to think really carefully about how to get the most out of those limited resourcing. And things like gaming can potentially erode that from that limited pot of money. So I just want to say I hear you, and that's part of the reason that there's some pending budget discussion notes on these slides is exactly the reason that you highlight. Thanks.
Can I just clarify a couple of things, because this is probably a longer conversation, but the quality gate, Brad, that you talked about, that would be a gate to getting into track 2 or track 3? or that's just a gate to getting savings?
I think from at least as of now, the framing would be it's a gate to shared savings. Are you suggesting a quality gate to like participate in 2 and 3?
Yes, I am.
Okay.
Yeah, I think that this should, be a, just not getting savings is far less of a deterrent than not being able to get into an opportunity for those savings. And I think it would help make sure that we, I know it sounds like you and I don't agree on the how well PCMH Plus did, but I think from my perspective, some of the flaws would have been would have been buffered if we had a quality gate, a meaningful quality gate to it. And I do reiterate that I think improvement, I want to, with PCMH, we wanted to improve and everybody in, we need everybody in. But I don't know that we need everybody in to track 2 and 3. So I think that's something where we expect already high performers, that I think. Another question. Now I understand from this slide that you're showing, I didn't see that in my slides, so I'm hoping I get an updated deck. That you're planning this to go to downside risk? Is that the intention?
I think we're definitely interested in thinking about how do we phase in downside risk over time in a asymmetrical way.
Okay, well, I'm back to deeply concerned, but okay, I'll let somebody else talk now.
So appreciate the thoughts and considerations, and I know this won't be the last discussion. Mark?
Thanks, Brad. So I am I guess I want to commend you and thank you for reflecting so much of what was discussed in the April 4 meeting around having options to choose from about alignment with commercial, around the options that include fee for service with flexible ad versus the hybrid partial capitation. Should I take that
Not
personally?
reflected to the record, Mark. I don't know what happened there.
Not sure what happened.
Yeah.
I'm try to figure it out while you're talking. That was weird.
Everything from here will be stricken from the record, I guess. So so I think that's I actually I didn't see these slides because they weren't in the deck. They seem directionally aligned with the kind of feedback we offered, and so I think that's great. I think that I don't know how to get at this, but I think that there's something that is implied here that concerns me. Going back, and it has to do with the comments that have been made from the very earliest part of this this series that began last spring, which is that clinical care has a 20% stake or role in influencing health impact. I think there was agreement amongst many around the table that the kinds of the factors that influence both getting sick and recovering from illness lie as much outside of primary care as in primary care. And so and I understand that you needed to focus on the primary care solution, but it's at this juncture that I think we need to discuss and figure out where in the record those previous comments about the role of communities and the community partners that are working on things like neighborhood safety, housing quality, blight, and access to food, nutritious food and that sort of thing. Those comments were made that there's both community assets to be mobilized and a role to be played by community members that is currently unfunded and for which there are no rewards. So if what we're talking about is there's $1 to be saved in Medicaid by either getting people to a healthier place or better managing chronic illness, that dollar will be saved between the state and primary care. That leaves no part of the dollar to be directed to support the work of communities and hospitals to basically sustain and scale the interventions that actually are necessary to achieve a meaningful Medicaid impact. So a dozen years of testing of ACO models with or without downside risk have shown you can drive some improvements in ED and hospital use, but that's not the same as having a fundamental effect on health inequities and, you know, the prevalence and of chronic disease and the outcomes. And so what I'm really wondering about is when, because I don't have such a strong feeling maybe as Ellen about whether there might be a downside risk component. The question is, are we talking about total cost of care model where the dollars go to either the state or primary care rather than to community that has at least a 70 to 80% role in achieving impact? I think hospitals and their community partners are prepared to mobilize a systems regional place-based approach that complements the primary care model. But if you develop a reward structure, this is the issue, Guy, from very early on. You said we have to focus on designing primary care. But if you focus on primary care and you have a total cost of care model that is $1 to be saved and it's already spoken for, then that limits downstream what you have available for rewards for effective and essential community-based activity. So my question is, how do we preserve the opportunity to direct maybe a 30% share of the savings to primary care and a 70% share of the savings to community partners to sustain and scale the work that is so critical to enabling the Medicaid population to achieve the biopsychosocial health and well-being goals that you set up at the beginning?
Mark, thanks for that comment. I suspect there's a lot of interest in making sure there is support of community partners and community organizations. I'll just note that one of the things here is under phase 3 next steps is really defining what services that considers a provider's ability to impact cost and utilization would be included, recognizing that we may not be looking at a total cost of care. I think this is a phase 3 portion of the discussion. Also recognizing that, being able to share some of those resources externally may require authorities that may take some time to kind of pave a pathway for. But I think there's a deep interest in thinking about how we can support communities long-term to provide care, acknowledging that I think, right, primary care is definitely not the whole solution. I think we hopefully try to be really clear that is part of a important cog in the healthcare infrastructure, but healthcare itself is only providing, improving people's health or managing 20% of their health and well-being. And there's a lot of things that happen outside of that. With that said, if we're identifying a subset of services that primary care can impact, then it does make sense to think about how do we make sure that we're encouraging and rewarding primary care providers for really trying to do a heavy lift for things that may not historically have been rewarded for. So I don't, and I'm not suggesting like 100% of all savings as part of this. That would be part of that, I think, consideration is like what would be, and then how do we think about this long term? Obviously, I'll just also know, as you know, there's a lot of some outstanding questions in terms of hospital payment reform efforts that DSS will be involved in, including through AHEAD, that may play a role in some of this. And Guy, you may want to add something else, so I'll turn it over to you to see if you want to add any more comments.
I have a very not substantive one. I'll just add, since Ellen and Mark both have rightly pointed out this slide wasn't in the packet you sent out, I will own that. Just for full transparency, we were debating a lot the pending budget discussions, how to thread the needle between trying to be clear on what we're thinking, but then also recognizing that the fiscal situation no one knows, and And anyway, so I just wanted to apologize. I think the slide is the only one that wasn't on the send up, but that, am I wrong?
There was one, Olivia, you can correct me.
Anyway, I own that. And I asked the team, we just wanted to make sure we got the language right, so I will.
We're definitely sending these out, just FYI, that's the plan. So,
So can I just tag on with modifying what is a complaint or a request to something that might actually be a proposal? And the proposal would be that, well, first of all, Paul Grady and Dr. Carden and the Northeast Medical Group folks and Joe Caranta and other groups have experience with doing total cost of care, shared risk in Medicare Advantage and commercial. And in both of those areas, you are closer to, especially commercial, covering the cost of care, whether it's the hospital component of care, or it's the physician specialty or primary care component. So it makes sense, especially in a commercial context, that the Anthems and the Cignas of the world would share in a dollar saved with the provider community. In Medicaid, where there's a fair bit of evidence that we don't invest enough in Medicaid, we don't have a big cost growth problem in Medicaid today, aside from the demographic problem of an aging population that will require more long-term care, and that's expensive. But we don't have a huge cost trend problem in Medicaid, and we do have an underspend problem in Medicaid. And this program is about rewarding work that benefits Medicaid beneficiaries. So one of the audacious proposals I would offer is that, unlike, and I'm offering this now because in the technical design, we're setting the parameters or the principles that inform the technical design phase. So what I'd offer is that the state should consider, and I'd love to hear from the advisory committee, an approach where, because Medicaid woefully underspends on hospital and physician and behavioral health services, that 100% of the savings is shared, not a 50% or less portion, contingent on achieving certain Medicaid impact goals. But I'd like to put forward this idea that if you're going to be talking about shared risk and distribution of savings, that 100% of the dollars saved should be available to reinvest in the provider community or to reinvest in the community. As a corollary to that, I would offer that a majority share should be directed to support effective system-oriented solutions that are implemented by non-primary care actors, including community organizations. So like a 70% share goes to those actors and a 30% share to primary care. It's hard to argue based on any of the evidence that's out there that if you have a positive impact on Medicaid long-term, the Medicaid health of the population, that primary care is the major driver of that. So the two things I would suggest is, one, 100% of any dollar saved gets reinvested for the betterment of the Medicaid population, because the state doesn't really have a cost problem, they have an investment problem. And two, that a majority share of the dollar go back to invest in the solutions that are needed outside of primary care that can be advanced by the health improvement collaboratives of the world, the Triple Aim collaboratives of the world, the health improvement alliances of the world. There are organizations or the Middletown Health Enhancement Community. There are organizations out there that are positioned to scale food security and child well-being initiatives that don't have the opportunity. They're not in the game. And it's really not asking a whole lot for the state. and I hope I don't come across as yelling or preachy, but I'm just trying to like make a point, and I feel passionate about it. That it seems to me that the state could really take a step forward beyond all these models that Medicare and other states have developed into one that recognizes the essential role that community partners play in succeeding with Medicaid beneficiaries. And I say that now in what seems to be the last meeting of the advisory committee before you go into the technical design phase, because I think it's really important we have that conversation when we're talking about shared savings.
Mark, thanks, and appreciate your passion. I mean, I think there's some alignment in that there is an essential role that community partners play. Some of the assumptions about concerns about Medicaid spend in areas, and that there's not any issues with our cost growth, are areas that probably would want to have a more nuanced conversation on. But we definitely can't, I don't think we at DSS, I can't commit to that, though we welcome hearing others' thoughts on it. Guy, anything you want to add on that?
Well, Brad.
Oh, sorry, I lost you for a second. Did you?
I was saying, I think you teed it up. You teed it up well.
CJ?
I just want to say thank you to Mark for saying that and lifting up the comments. It's good to know that at least somebody with privilege hears us. I don't think it's a big of an ask. I think especially with what is happening right now in community, we're seeing more and more people being unhoused. We're seeing more and more people income unstable, job unstable. You know, we have a lot of folks needing mental wellness services, food, all of that. But we also have a lot of unspoken heroes in the fight who themselves are facing their own challenges. So I don't see how this wouldn't be a progressive move. You know, Connecticut claims to be progressive, to demonstrate this level of support for all doing the work. And need it. We are the community. You want us here? Fund us. Because guess what? We'll do it anyway. Let me tell you something. If you didn't know you was today years old when you found out, peer support is as old as Black history. So give us the funding. Thank you again, Mark. That's all I got to say. Peace.
And maybe one additional thing I'll just add is that I just want to bring this back to saying we're talking about a slice of work that DSS does in terms of primary care payment reform, acknowledging the need for acknowledging both the current work that community-based organizations perform in having a huge impact on the broader Connecticut community, and especially Medicaid and CHIP members. Just want to acknowledge that it's obviously instrumental, but there's other things that are also going on that we've discussed a little bit, including some explorations around opportunities around 1115s to enhance health-related social needs. Not obviously we currently are not moving that forward, but that is something that has been explored. Opportunities that may come through our HEAD application to think about community health and well-being as well. And so just to say, this is something that DSS is interested in. This may be a challenging area to enact this specific change. And some of it has to do with, part of some of the limitations that we have are going to be bringing this and looking for a budget to roll out any changes that are recommended through this. And so we do need to think about how we'll fund that. What does that look like? And so, if there's shared savings that don't go back to the state, that could create some challenges, as well as just authority challenges with allowing us to do this. Those are not insignificant, but I do want to just say we understand, we hear you, and we want to hear more. And I know Angela, your hand's up. I saw your comment, but please weigh in. We definitely welcoming the comments.
Yes, I just wanted to lift up to echo some of the comments just heard. And just to ask the question whether the section 17 of Public Act 23-171, if you all have done the due diligence working with OHS and OPM to drive some of those potential savings back to the community. That's a question.
Off the top of my head, actually, Guy, do you know which?
I can
Go ahead.
take that,
Great. Thanks, Mabel.
Fred. Hi, good afternoon. Just the quick clarification, are you referring to the report that DSS was charged with producing and submitting to the legislature next year?
This is Angela, and section 17 calls for DSS to develop a strategy to improve healthcare outcomes, community health, and health equity to support Husky Health members in collaboration with OHS, with OPM, and other agencies as appropriate.
Yeah,
what has been done in that realm?
Yeah, I can take that. That report is due to the legislature January of 2025. The commissioner has charged me and Joel, or the policy division here, to take the lead on that. We have not yet begun official work on that. We've done some internal planning and how we're going to approach that. We do intend to consult with not just the parties listed in the legislation, but other parties and community including community organizations as well. So we intend to start doing that over the summer when we can, like everyone else, we're a little resource strapped. So we anticipate getting a little more help over the summer and after the session's over to be able to dig into that.
Just as a follow-up, so this committee is sunsetting with that work still yet to be done by January?
I don't think the intent, Brad, is for this committee to sunset. It's going to come, there's going to be consultation opportunities with this committee on a quarterly basis. Is that correct?
Yeah, so exactly. And we can talk in the next.
So that means 2 meetings in 6-7 months. Is that what you're saying?
Angela, if it's okay, we can maybe pin that one till that very end, and we'll talk about kind of logistics for moving forward, if that's okay.
I'll just make one more comment, just as I thought I'd respond to some of the discussion and points that Mark raised. I think I think we're very much interested in ways that we can find mechanisms to invest back in community and community organizations doing good work. It's also a very important, crucial policy question as to the mechanism by which that investment happens, which is one, is it optimal for that investment to happen through healthcare entities, or is it optimal for that investment to happen through other processes? So in the case of shared savings, and again, we can't take any position on this right now, but in the case of shared savings, if that savings were to accrue to the state, there would be opportunity for community-based entities through the normal democratic process to access, funds through state budgeting process. Whereas if that savings were to be required to be invested through healthcare organizations, you would have community organizations being in the position of requesting those dollars or approaching healthcare organizations to fund the work. Both, I guess both are, potential pathways, but I think there's pluses and minuses to each way.
Thanks, Michael. And just maybe to add, the other important piece is that, and I think we definitely discussed this previously, is the importance of the multi-agency alignment to make those investments that, Medicaid, really can't be, Medicaid agency can't be the only agency. And I know, and we're not, there's many agencies very interested in this and thinking about community investment and community well-being. And so just making sure that that's considered and has been brought up, I think, by others on this committee in the past. And so there's still work being done there. And I know Maywool and others are involved in conversations. Angela, your hand's still up. I just wanted to make sure if you had any thing you wanted else to say before we moved on to Ben and then Ellen.
No, I'm good.
Ben?
Hi, thanks. Can you guys hear me okay? I'm connecting through a different means today.
We can hear you, Ben. Yeah, absolutely.
Okay, great. Thanks, Keith. So I just wanted to, as we're thinking about moving on now to the technical design, I think there's some broader sort of structural things that Mark, I think, has rightly pointed out that are worth reiterating at this point. I recognize completely that we're here today just talking about a primary care model. And we've acknowledged, I think, in every meeting that it's just one piece of a broader system of care that patients who and members who have Medicaid are reliant on. And for this community and this population in particular, non-healthcare factors play such a major role. I think that there are, I think it's important for us as an advisory committee, and I would welcome the opportunity to, perhaps in a future meeting, to hear from DSS about what share of the savings that's generated is available for this program. Because although we're not thinking about the broader systemic changes that might come down the path from DSS and other conversations, how much we carve out for this program has implications for those future programs that we might be thinking about. And we know that non-healthcare factors can have a massive, massive impact. Sometimes, I've heard things that it's up to 80% are non-healthcare factors. I think the other thing that is that's important for us to think about, and Mark was right to point it out, we don't have a spend problem in Medicaid, we have an underspend problem. And if we're looking for ways to channel funds back towards entities that accept Medicaid, then having 100% of the savings redirected towards providers is a way to get there that would be beneficial also for the state. So I think that 100% reinvestment principle is something that we should strongly consider.
Thank you, Ben. Guy?
Thank you.
Thanks. Actually, Stephanie, I saw you had a question in the chat. Do you want to go first, and then I can go after if you want?
Yes, thank you for the opportunity. I don't mean to belabor the point. I just really want to, I'm curious about the value, like how DSS and OHS and or DPH, like how the work of collaboratives funded through the Health Enhancement Community Opportunity are seen, whether or not there is a perception of value to the improvement of folks' health, and like just considering the work that is being done really on the ground level through these multi-sector, multidisciplinary partnerships. And if yes, I guess I'm echoing some of my other friends and colleagues on here who are saying that a significant way of investing in continuing to support the work that is happening, because that round of funding ends at the end of this month, right? So, but the need for the work that is being done doesn't end because the funding runs out. So I'm curious about whether or not the work that we're doing in community is seen as valuable and complementary to what you're trying to do with this other bucket of payment reform. And if yes, then I'm hopeful that through whatever next phases of the work are happening, that and a significant financial and other investment is made into these groups to refine the work that we're doing and to scale it up.
Thanks, Stephanie. really nice to hear from you. And with Commissioner Barton Reese was able to join. I was going to chime in. Commissioner, if you're able to get off mute.
Okay, thank you. They had to move me to another room, so I'm kind of trying to maneuver the technology in here. So Stephanie, I really want to thank you for your question, and I really do appreciate it. I would say, in speaking for myself and also speaking to the other commissioners that are in the space of health and human services, that the commitment that you've made and your colleagues have made is very, very highly valued. So I can understand and appreciate that there needs to be a commensurate fiscal investment that is a reflection of that value. And I think that is really what we're really trying to figure out how we can do here, knowing that we have really limited resources as a state. And I do hear this feedback quite often that if services are valued, then why isn't the state paying more for them? And I think that's a question that we do ask ourselves, and it's not so much why, but how, and to what extent can that continued increased payment be sustained? So it really is much more of a fiscal question than it is a question about whether or not the work that you and your colleagues do is valuable, is impactful, makes changes in people's lives. I think all of that is without question. So I wanted to be very clear about that. I think what Brad and Guy and I are really trying to do, along with the rest of our Medicaid group, and even all of us here at I was going to say DDS, DSS, DOH, OHS, is really trying to figure out how we can make deeper and more impactful investments, knowing that we are really struggling with significant fiscal constraints. So, Stephan, I would invite you to have that conversation with us if you have some ways that we could do that, knowing that we really do have some significant fiscal constraints around how much we can put in and and how it might make sense for us to do that.
Thank you. Would love to.
Sure, that would be great.
Thanks, Commissioner, and thanks, Stephanie. Guy?
I'm going to go back to some of the earlier comments, which I think are spot on, that primary care practices, primary care providers play an important role, but so do many other factors: social determinants of health, the communities that people live in, hospitals, etc. And I do want to gently push back, though, so I think that's definitely true. I want to gently and respectfully point out that two things can simultaneously be true. Thing one, primary care explains only a minority of differences in healthcare costs and quality. And thing number two, it still makes sense to have a model where we compensate and reward and encourage primary care providers for achieving outcomes that are within their domains. I mean, to take a maybe a little bit of a silly example, like COVID, there's really good evidence that social factors, that community factors, obesity, age is a really strong determinant of people's impacts from COVID. Also, vaccines really help, and both things are true. Vaccines in the margin can really help, and also other factors matter a huge amount. Similarly, here, primary care practices, there's really good research that they can impact cost, quality, things like that, and other factors do as well. And so I don't think it's I think it's a little bit of a fallacy, or I just want to clarify. I don't think it's impossible for both of those facts to be true. And I think when we're thinking about the suite of things that the commissioner and Maple and others are going to lead to address all the important concerns that we all have raised, I don't want anyone leaving this room thinking that we're thinking primary care is everything. I think we're saying it's an important slice, and we want to try to solve for that. And we also, to the commissioner's point, want to think about all of the other really important factors that go into determining health. So I just wanted to clarify that. Thanks.
Thanks, Guy. Ben?
Thanks, Guy, for that. I just wanted to make sure that if there was any misconception about what I was saying, I wanted to make sure I was clearing it up. I don't personally, I wouldn't be here if I didn't think that primary care had an important role to play in improving the health status of our community. And I think that we underpay primary care. And one of the things that I have appreciated about the direction that Connecticut is going is improving reimbursement for primary care. And this can be helpful with that. I just think that as an advisory committee, it's important that we that we have some point of view about how much of the savings we're preserving for all of these other actors who have such an important role to play. But that's not to undercount how crucial primary care is to our success.
Thanks, Ben. And I'm just going to define for just one thing, just to say that clarification is really helpful. And one could certainly imagine a model that encouraged, since we know it takes a village in terms of primary care and hospital, the community partners, social determinants of health. One could, I think, from first principles, we'd like a model that rewards and encourages each of those really important actors to help Medicaid members. I think that's where you're going. I think we're probably saying the same thing. Anyway, just want to clarify. Thanks.
So it's just we're making the decision about how much of the dollar is left over for those other we could potentially be making a decision now about how much of the dollar is left over for those other actors. And so in the absence of that broader framework, I think I'm repeating myself.
Yep, thanks.
Mark, Ellen, and then I want to make sure we have a little bit of time just to touch base on next steps. So Mark, and then
I'll be brief, thanks. So two things. What I think would be great to reflect in a principle is two things that could be committed to without obligating the state from a budgetary perspective. To share 100% of a savings dollars doesn't cost the state anything, right? 100% of a dollar is a dollar saved that you would have otherwise spent had these activities not occurred. So that's a budget neutral commitment to spend to reinvest 100% of what's saved. The other is that, to go to the commissioner's remark about, well, there are budgetary constraints to upfront funding what needs to happen in communities. And I would say that Medicare has for 15 years operated an ACO model where they don't make upfront payments, but that doesn't mean they don't have a stake and an opportunity to earn rewards. So you don't necessarily have to have a solution for new investments in the community work to acknowledge that the community work plays a role, to have certain performance measures that might be specific to the community partners, and that might be the basis for conferring a share of the dollars saved to support the work of community partners. And when I say community partners, I mean a mix of non-primary care healthcare and community-based organization partners, community action agencies, health departments, and that sort of thing. So the main thing is, I think that there could be a commitment to those two things, a share of the dollar going outside of primary care to support the work in the community, and 100% reinvestment that are 100% budget neutral, and arguably could be in the platform that sets the phase 3 folks into their sort of onto their sort of technical problem solving.
thanks, Mark. And I hear you on the budget, and Charlie, I'll just make one brief comment that one of sometimes the savings that are accrued in one year are then have to be paid out in another year, which can create some fiscal challenges as it pertains to shared savings, but understand that generally the framework. Ellen, and then I think we might have some time for Jim to comment as well.
I just want to maybe do a little level set because we're having, it sounds like a values discussion around the value of primary care versus community services, which is a really frustrating one for me because they're both incredibly valuable and need to be supported. The other concern I have is that we're talking about divvying up savings, which have been few and really looking back at the evidence, we're not talking about piles of money here. This is, I think, an argument around that missing the point is that we need to invest more in the drivers that improve people's health and, by the way, save money. And I think that value discussion we just have shouldn't be about versus, giving, what 70, 30, 100%, whatever. We should be talking about how do we invest in those community services that improve people's health. And it shouldn't be contingent on savings. First of all, it's attenuated. It's, it's certainly nothing, as somebody who's worked in a lot of community service organizations, you wouldn't be putting that in your budget right now. That's down the road, and it's no way to invest in things. I think it's, incentives are important, but we should really separate that from what the state needs to be doing, because we underfund public health. We just do. And that's probably beyond the scope of this committee.
Thanks, Ellen. Jim?
Just real brief, and I'm sort of just, as I'm listening to the conversation, I think it's really important. I understand the purpose of this is primary care needs more investment. However, we're going to design that a bit. But living in this world where we're trying to manage total cost of care, the thought of us trying to accomplish that on the backs of primary care is so completely unrealistic in terms of the impact of hospital specialists, community partners, for us to do what we need to do. And so to Mark's point, there's no question that if you're trying to manage that entirety, both in terms of the outcomes, quality, it's so much bigger. And so we have to put this in context. If we're trying to solve primary care, it goes a little bit, let's make sure we're solving what we actually want to put primary care control and what we're trying to enhance, whatever that may be. But we have to put it in the context of a broader problem that we have in terms of managing this population in a robust way, which is much bigger than a primary care issue that we could even begin to tackle with just primary care, or expecting that kind of performance out of that group who's already stretched. So thanks.
Thank you. And I think, just to reiterate, I think we likely all have a lot of alignment on the problem, and I think it's that there are all of these issues across the board, including in primary care, including in community investment and social terms health. It's what's the solution? And I know Mark's proposed solution is one that I think deserves some consideration, though I think we have concerns about operationalizing and fiscal impact, et cetera, again, year over year. But I think we are aligned on what the problem is and where the problems are, and the solutions are probably going to be the challenge, which are significant. And I don't mean to minimize those. So I just want to highlight where we are aligned and where there is alignment. And I do want to make sure to touch base on some next steps here on where we're headed. So thank you. Thanks, Olivia, for taking those notes and for moving on. But just to say, we're finalizing some of the details here on who interested in participating. We'll plan on sending some communication out via email in the coming weeks. And so we're really looking to articulate these technical disease details on kind of the model we just discussed. So the goals of that are really to collect the feedback on decisions to be made in the development of the program, and discuss key budget, authority, and program implementation model decisions. And just as a reminder, the Technical Design Committee may have members already existing from this group. We would be meeting monthly. We would bring it back to this larger group on a quarterly basis, or every third month, to report back and get more feedback. And we'd also be reporting out to the MAPOC Care Management Committee as part of this work, including there's reporting structures through CHN's Community Advisory Committee, Member Advisory Committee as well. So the sample discussion topics would be things that we discussed, obviously, in more granular detail around the hybrid population-based payment, flexible fund shared savings, performance-based payment parameters, quality measure slate, performance standards, payment structure detail. So really getting into, again, the details, the weeds on this, some of which you highlighted today, the importance of. A lot of these programs come down to the details of them and how they operate, to whether they're successful or not successful, whether they're burdensome, whether or not. And so we will need to talk through all of these pieces. Again, looking for us to shift really from this more open-ended co-design to a more kind of focused, specific question, going through some examples of what DSS is thinking of getting feedback along the way, similar to what we have done with the maternity bundle, where we really use that process to help shape the program in a way that was really informed by both community and providers. So I will pause there to see if there's any questions about this, so that Ellen, please chime in.
So this isn't an exhaustive list of what the committee's going to look at. Will they also look at the issue I brought up before about qualifications and gates, about who qualifies for, track 2 or track 3 and provider risk, or is it purely just the providers decide?
Sorry, I froze there for just a second, but just as these are examples, this is not meant to be an exhaustive list, Ellen, for topics. I don't want to say definitively all of the topics we will cover, because some of those are still being worked through, but this is not meant to be an exhaustive list.
So I heard maybe, is that right?
You mean in terms of your ask? We'll definitely take that back as we look through it. I mean, qualifications for providers are definitely going to be on the things that we have to discuss. That's going to be on provider qualifications. Again, I think as Guy and you both had noted, we're planning on having a broad-based provider engagement for providers in the community. With that said, we discussed this before, do we need to think about size component to it, even if there's more of a capabilities based. So there's a bunch of pieces around who can participate in which of these tracks, what do the tracks actually look like, and some questions will come up because of other decisions that will be made, if that makes sense. So just to say, I don't want to overcommit us at this time, but I think we're definitely going to be diving into topics around what you just asked, Ellen.
Okay, thank you. It sounds messy. I like it.
It always is a little messy. Well, I just will say, with the remaining couple minutes, appreciate the lively conversation. I think it's welcome. We appreciate it. And we definitely are looking forward to diving into more details here. And also want to thank Guy for his continued participation and engagement. And I know we'll be sad not to have him in the next phase of this work, but know he's had a huge imprint on the work to date. Anything else Guy you'd like to share, or maybe before we wrap up?
I just wanted to say thank you. This has been a big time, and this isn't the end, but this is the end of one phase. I just wanted to thank you all. The time you've invested, the robust discussion, I think has been really helpful. And even when we don't always agree on everything, I think the discussion and the listening is really, really, really important for making this product better. And I know in phase 3 that will continue. So I just wanted to say thank you for the considerable personal investment you've all made in this to date.
Yes, thank you. I will send the updated slides out, and I know it seemed like it wasn't recording, but I checked and it was recording. So yeah, it looks like we're in good shape there. All right, everyone, thank you so much. Appreciate it. We'll be in communication via email.